Yes.
Thank you, sir. Good evening, respected doctors. On behalf of Palsons Derma Private Limited, it is my privilege to warmly welcome all of you to this scientific masterclass. Founded in 1984, Palsons Derma has remained dedicated exclusively to dermatology for over 4 decades. Guided by our philosophy, passionate about dermatology, we strive to bring innovative, quality-driven, and science-backed solutions that help dermatologists deliver the best possible outcomes for their patients. Our vision is to be a trusted partner in advancing dermatological healthcare through innovative, scientific excellence and meaningful collaboration with the medical fraternity. We are happy to introduce the Derma Masterclass Series, an academic initiative comprising 25 webinar sessions designed to systematically cover the major chapters from the dermatology textbooks. Our objective is to provide a platform for academic enrichment through expert-led discussions, clinical insights, and recent advances. It is my privilege to introduce our distinguished speaker for Derma Masterclass Series 4, Dr. Biju Vasudevan. Dr. Vasudevan is MD in Dermatology and FRGUHS in Dermatosurgery. He is currently Professor and Head of Department of Dermatology at Command Hospital, Chandigarh. He has an impressive academic and research profile with 242 publications and more than 250 presentations to his credit. He has also contributed extensively to dermatology through 10 edited books and 62 book chapters. Dr. Biju Vasudevan has held several prestigious positions, including past Editor-in-Chief of MJAFI, past Deputy Editor of IAJDVL, Joint Secretary of IADVL in 2016, Vice President of ACSI during 2020-21, and past Academic Chairperson of ACSI. His contributions to dermatology have also been recognized through several honors, including the Young Dermatosurgeon Award, Ellen Sinha Memorial Award, IADVL Cystopic Oration by Dr. A.S. Thambaiya Oration. His key areas of interest include clinical dermatology, research, and dermatosurgery. With such a rich blend of clinical expertise, research experience, academic contribution, and surgical expertise, we are truly honored to have him with us today. Ladies and gentlemen, please join me in warmly welcoming our distinguished speaker, Professor Dr. Biju Vasudevan, for Derma Masterclass Series 4. Topic: Update on Collagen Vascular Diseases, Clinical Perspectives. Over to you, sir.
Good evening, everybody. Is my slide visible? Are my slides visible? Hello?
Yes, sir, you are audible.
Okay. Good evening, everybody. So welcome to this update on collagen vascular diseases. So this is a topic which is very close to my heart, and we'll be dealing with this topic basically in 3 sections. That is systemic lupus erythematosus, scleroderma, and dermatomyositis, because I thought that these were the 3 important to be discussed. And there are a lot of new findings, treatment options, which are coming in these conditions. So we first come to systemic lupus erythematosus. So this is how I would deal with the topic: the disease overview, pathogenesis, some of the risk factors. And what is interesting is this type 1 interferon and B cell biology. So that's what is important in the pathogenesis. Clinical manifestations, how to monitor, how to treat, certain conventional therapies followed by the biologics, and certain drug spotlights. So as we all know, SLE is a chronic systemic autoimmune inflammatory disease. It has various manifestations. What drives it is the immune dysregulation. You all know there is immune complex formation and complement consumption, which produces the variable involvement of various organs. It can be from mild, where only skin is involved, or to the musculoskeleton and various organs. The usual common involvements systemically are lupus nephritis, the neuropsychiatric disease, lung involvement in the form of diffuse alveolar hemorrhage, which can be catastrophic, and the antiphospholipid related thrombosis. We all know that the female to male ratio is very high, 9:1. The age range is typical middle age. The prevalence varies per population, and it's very high in the Black, Hispanic, and Asian population. Now, this is very important, the immune dysregulation cascade. So what triggers systemic lupus erythematosus? So now what is thought of is that it is the defective clearance of apoptotic debris of the cells, which is an important trigger factor. This along with then leads to the neutrophil extracellular tracts, neutrophil dysfunction. This leads to exposure of autoantigens, and there is a plasmacytoid dendritic cell activation. Now all these now lead to, this is the most important step, the type 1 interferon search. Now this is thought to be the main pathophysiology behind SLE now. This leads to the aberrant B activation, sometimes T cell 2, autoantibody production, immune complex deposition, and the tissue inflammation and organ damage. Now this organ damage leads to further debris formation, and this amplifies the defective clearance of the apoptotic debris, and this is supposed to be the central pathogenesis of SLE. This apoptotic debris failure to clear it provides the persistent autoantigens, which is the autoantigens of nucleic acids. Now, this tissue damage, as I said, is the one which keeps the cycle going. Various genetic factors we all know. There are epigenetics involved, aberrant DNA methylation patterns. We did a original study from the Parent Institute FMC, and we found that there are various DNA methylation patterns which are involved in pathogenesis. This is under publication. Various genes are involved. It's not a single one. And we all know the environmental triggers, that's ultraviolet light, which triggers the keratinocyte apoptosis, tobacco smoking, viral infections, especially EBV, and hormonal factors may also have an important role to play. So it's basically a gene environmental interaction, which is very important. So as I earlier said, this type 1 interferon pathway is central to pathogenesis. Self-nucleic acids, which then activate the toll-like receptors. Again, very important part in the pathway. Then the interferon release. What is important among the interferons is the interferon A-R1 receptor signaling, which leads to the expression of interferon-stimulated genes and the amplified immune pathways, that's the B and the T cell autoimmunity. So it is found that in various studies now, 60 to 80% of SLE patients have this elevated peripheral blood interferon-stimulated gene signature, which is correlating with disease activity and organ involvement. So very important pathogenesis advance, which we are seeing now in LE. Now, so thus, if you have something which blocks this interferon AR1 receptor, that is where the treatment options, especially anifrolumab, comes in. So what happens in cutaneous LE? Again, it is found that it's a type 1 interferon, which is the dominant molecular signature across all these subtypes. We all know UVB radiation induces keratinocyte damage, apoptosis, and this is what translocates these autoantigens to the cell surface from the nucleus. And the interferon-stimulated genes are upregulated in both lesional and non-lesional skin, which paves the way for the interferon AR targeted therapy, which we are now looking at as an important advance in the treatment of LE. Again, explained here better, UVB exposure, DNA damage, antigen exposure, and then the upregulation of the interferon-stimulated genes. Now, another important factor to this is the plasmacytoid dendritic cells. So these cells in the lesional skin are found to be the principal source of type 1 interferon through the toll-like receptor 7-9 sensing self-nucleic acids. And there's a receptor on these plasmacytoid dendritic cells called as PDCA2. Again, it will keep repeating when we come to treatments. So this is a selective target by which we can target LE. And if we deplete these plasmacytoid dendritic cells, then it basically reduces the keratinocyte damage and T cell recruitment. So now we have a molecule which is coming up as an anti-BDCA2 antibody, that is litifilimab, another drug which is very prominently coming in various trials for LE. So again, the plasmacytoid dendritic cell, toll-like receptor 7-9, and the interferon signal. Now, the cytotoxic T lymphocytes, which drive the keratinocyte processes, especially in cutaneous LE, is very important part of the pathogenesis, because it is this cytotoxic T lymphocyte mediated damage which releases further autoantigens and provides this feedback to the PDC. We also know that B cell heterogeneity is important. We'll come to that later. That basically is also important for discoid LE. So now, if coming to the autoantibody sources, now this is interesting. Now you have two types of B cells, and which is the predominant B cell also probably determines the phenotype of LE. So if you have a predominant short-lived plasma blast as the ones producing the autoantibodies, they are susceptible to the CD20 therapies, that is rituximab and obinutuzumab, and is also better susceptible to the CAR cell therapy. Whereas if you have the long-lived plasma cells which are CD20 negative, they are not greatly amenable to treatment, and these are the ones which probably give rise to the treatment-resistant phenotypes of SLE. So now if we have the cutaneous LE pathogenesis explained in better clarity, UV exposure, keratinocyte apoptosis, autoantigen release, the plasmacytoid dendritic cell activation, which gives rise to the type 1 interferon, which drives the chemokines and then leads to the increased cytotoxic keratinocyte killing by the cytotoxic T lymphocytes and the B cell autoantibody production. And these are the feedbacks for this apoptotic pathway. So this is how the cutaneous pathway differs from the systemic one. So we all know LE with its various manifestations, mucocutaneous. We know that renal, where lupus nephritis is the major driver of morbidity, pulmonary, hematologic manifestations like cytopenias and APLA, musculoskeletal, neuropsychiatric, the cardiovascular like pericarditis, and the GI and the ocular manifestations. So all these can be explained by the pathophysiology, which we have discussed earlier. So we all know that acute CLE is strongly associated with SLE, subacute moderately, and the lowest, of course, is with DLE. So based on these phenotypes also, the pathophysiology can be explained better. We know the diagnostic and classification criteria for SLE, which is the entry criterion being the ANA. Then we know that renal carries a huge weightage. So serum creatinine, urine protein creatinine ratio is important. Serological, that is serosal, that's the pleurisy, pericarditis, and the sterile peritonitis. Mucocutaneous, we all are familiar with. Neuropsychiatric and the antibodies, specifically the anti-dsDNA, anti-SM, anti-cardiolipin, and low complement. So this weighted scoring, which is given by the ACR ULR 2019, actually classifies this disease much better. We can now also disease activity monitoring can be done with SLEDAI, the BILAG, as well as the physician global assessment scopes. Now, Class C is the cutaneous LE disease area and severity index for cutaneous LE. We've already discussed the systemic ones. It is akin to the C-E for dermatomyositis. And we also have the disease area and severity composite skin score also now too. These are the various scoring measures which we can use to delineate the severity of the disease. Now coming to therapy options. So hydroxychloroquine, we all know sun protection, of course, along with hydroxychloroquine is the foundation therapy for SLE, as you can say. So hydroxychloroquine reduces flares, improves long-term survival. Of course, it requires periodic retinopathy screening. The other cornerstone is glucocorticoids, which gives a rapid control of the active disease. The goal is to basically give the lowest effective dose. What we prefer in dermatology is usually 5 to 7.5. The rheumatologists even go to as low as 2.5 to reduce to that dose daily. When we need steroid sparing agents, usually mycophenolate mofetil is what we go to as a thioprin. Cyclophosphamide, of course, when we have lupus nephritis. Now coming to the targeted biologics and the cellular therapy, that is what we'll come to it in detail because that is really the recent advance. So if you see belimumab, now this is a anti-BAF. It was approved in 2011 and is mainly used for SLE. This is one of the first therapies which is approved after 50 years for LE. So it's a landmark improvement in therapies. It also, of course, helps in lupus nephritis. Voclosporin, which is a calcineurin inhibitor, was approved for lupus nephritis. Now, this is important, anifrolumab. Now, this is the one which is the anti-interferon AR1 drug. This is approved 2021 for moderate to severe LE. Rituximab, we all know, has been used mainly off-label in refractory LE. Now, there's a new drug which has become approved. That is October 2025. We have obinutuzumab, which is a glyco-engineered anti-CD20. Now, this is very good for lupus nephritis. The JAK inhibitors, of course, now find a role in almost all cutaneous diseases and its systemic associations. However, there are drugs as of now investigational going on for treatment of LE. There are certain areas where it will be useful, which I'll come to later. As I discussed earlier, this litifilimab, which is an anti-BDCA2 present on the plasmacytoid dendritic cell. This is another one which is under trial for cutaneous and systemic lupus. Ustekinumab has been used very rarely too. So this, we come to precision medicine. Now, based on what is the dominant phenotype, we do have now the drugs which can probably target them. And therefore, when you have different phenotypes of LE, there are different drugs which may be acting on them. And that is what is probably going to be the future of treatment of LE. So if you have an interferon dominant signature, so then you have a drug called anifrolumab. If it is plasmacytoid dendritic cell dominant driven pathway, then you have litifilimab. T cell dominant, you look at a new drug which is anti-CD40L called as dapirolizumab pegol. It's like we've seen a previous drug which is a pegol there when it is psoriasis treatment. Then we have B cell dominant. Then the drug to go to would probably be belimumab. So now as we have oncotherapies, that is anti-cancer therapies, now we'll have also probably determine which is the dominant phenotype and then go to the drug. So this is what is going to be precision medicine for the future. So just to recap, anifrolumab, litifilimab, belimumab, dapirolizumab pegol. Then we have the JAK inhibitors. So we have deucravacitinib coming in for a kinase inhibition pathway, which is a type 2 inhibitor. Baricitinib has been used in LE. Iberdomide, which is an immunomodulator. Now, this is found to be useful in skin disease. So this is something which we will hear more frequently now. And then we have something called as enpatoran, which is an innate receptor blockade that is of toll-like receptor 7 and 8. As we had discussed previously, it's important in the pathogenesis of LE. So anifrolumab is basically a human monoclonal antibody that binds to the interferon AR1 receptor, blocking the downstream signaling of all the type 1 interferons. So this is what will target the interferon signature, which is central to the pathogenesis of LE as recently being found out. There is a problem. You can have increased herpes zoster infusion-related reactions. So these are the things to look out for. So the subcutaneous formulation is expected to come out soon. Voclosporin, the next generation calcineurin inhibitor, is a kind of development above cyclosporin. It basically gives high potency T cell activation inhibition and the inhibition of the interleukin-2 transcription. So various trials going on, and it is found to be better than cyclosporin, of course, and can be combined with various other drugs. As you can see the improvement here when you're giving it along with placebo and NMF. Rituximab, we all know. We come to obinutuzumab, which is a glyco-engineered type 2 anti-CD20 antibody. Now, this has an enhanced antibody-dependent cellular cytotoxicity, much more sustained B-cell depletion than rituximab. So, basically for lupus nephritis, it is supposed to be a good drug. Now, this is the anti-BDCA2 monoclonal antibody, which inhibits the plasmacytoid dendritic cells. Now, this is the one which is found to curb the interferon alpha at its source. So, could be a great drug. And therefore, it was granted breakthrough designation in Jan 2026. And this is also probably going to be the drug for the future. Now, type 2 inhibition with deucravacitinib, probably for the skin lesions, this is a drug which is going to become coming to be used more frequently, especially for the cutaneous LE. And of course, its oral administration being an advantage. Belimumab, as I earlier said, was one of the first drugs to be coming in for LE in this generation after 50 years. It targets the B cell dominant phenotype and is definitely going to be one of the drugs for SLE, for the generalized SLE. Now, this is something where you have a T cell dominant phenotype. This is a drug which is probably going to be the future, dapirolizumab pegol. CAR cell also being used in LE. You can see how, of course, it works. All of us are generally up to date as to how it works. So it has been tried in LE, and there has been some favorable reports for it. And probably this is another therapy for, of course, all resistant types. This is what is also going to be one of the therapies for the future. The newer ones I have told earlier, Empeteron, which is a toll-like receptor 7/8 antagonist. This is a cerebron modulator. This is iberdomide, baricitinib already being used, and especially in cutaneous LE, and various other new drugs in the pipeline. So we have now newer biomarkers in urine. We have the naive B cells which are being monitored, especially for the CAR, discussed in detail about interferon gene signatures and various algorithms being driven by these pathways for precision medicine treatment. And as I said, whether it's an interferon signature, a PDC infiltrate, a T cell infiltrate, or B cell will probably decide which therapy we go to in the future. So that was about SLE, pathogenesis centering on defective apoptotic clearance, type 1 interferon. So now coming to the targeted biologics and biomarker-driven precisions with treat to target. And CAR cell may also be a future. Similar for the cutaneous LE, we are getting now probably targeted therapies like anifrolumab, the litifilimab, deucravacitinib, belimumab, and the dapirolizumab pegol. So these are the recent advances for SLE. We now go to the second disease, which is scleroderma. Now, we all know that probably this is the disease where you have a lot of morbidity and an important component of the triumvirate of scleroderma, dermatomyositis, and SLE. So this is how I would be dealing with this topic. So we all know that there is a triad of vasculopathy, autoimmunity, and progressive fibrosis. Now, this is a huge issue with scleroderma, and we all know the fibrosis. Of course, again, with the female predominance, we all know how it varies with various populations. The classification, the ACR-ULR criteria, 9 points for the skin thickening of fingers of both hands extending proximal to the metacarpophalangeal. That is itself sufficient to diagnose, along with, of course, puffy fingers, fingertip lesions, telangiectasia, Raynaud's, pulmonary arterial hypertension, and the abnormal nail fold capillaries. So we also have the antibodies. Of course, we know the two important ones, the anti-centromere and the anti-topoisomerase 1. So these are the key molecular changes. The vasculopathy, of course, we all know autoimmunity drives the chronic inflammation. There are basically the activation of the various cells leads to cytokine release and the vasculopathy. The fibrosis can be triggered by that, and the fibrosis in turn can trigger the hypoxia, which leads to the vasculopathy. So endothelial cells, definitely probably the area where one of the important pathogens lies. Nitric oxide, endothelin 1, we all know why this is important for the drug. VCAM1, ICAM1, and the endothelial to mesenchymal transition. So these are the things which could drive the various factors, the vascular, the immunity, and the fibrosis. Now, another interesting thing is probably now there could be origins in the myofibroblasts, the pericytes, the vascular smooth muscle cells, of course, we've seen, adipocytic progenitors. So these are all the targets which are being looked at for various pathogenetic factors and to identify novel anti-fibrotic agents. Fibrosis, we all know, is the issue. So these are the targets which are now being researched upon. Raynaud's phenomenon is the earliest and the most common presenting symptom, and that is what we need to pick up early for early diagnosis and prevent organ damage. So we know that puffy fingers, if we get antibodies, and the abnormal nail fold capillaries. This is where a dermatologist is very important. So if you have enlarged capillaries, reduced density, avascular areas, we can pick up and also correlate the disease activity. So this is one very important place where the dermatologist can provide an early diagnosis to the rheumatologist or the other specialists for early preventing damage and early treatment. Clinical manifestations, we all know sclerodactyly, telangiectasia, microstomia, finger contractures. We all know what is limited when it is below the elbows, knees, diffuse cutaneous, of course, when there is diffuse involvement. The modified Rodnan score can be used to assess the fibrosis, and definitely the higher score correlates with the higher mortality. Now, these are the drugs which are used for scleroderma. We all know methotrexate and rituximab are the ones which are grade A and helpful for the fibrosis. The other drugs are basically tocilizumab, mycophenolate, and cyclophosphamide. Coming to each component, so you have digital vasculopathy and Raynaud's, where the calcium channel blockers are usually first line. Then we have the bosentan now and the PDE5 inhibitors, that is sildenafil and vardenafil. Then you have, if you have refractory cases, of course, you have the IV prostanoids. These, of course, the same bosentan would help reduce the future pulmonary arterial hypertension. So it's a very good drug to use for the initial Raynaud's. Interstitial lung disease, now we have nintedanib, which is an antifibrotic agent. We have tocilizumab, anti-interleukin 6. And of course, since we can't use methotrexate, the immunosuppressants would be mycophenolate and cyclophosphamide. Now we have biomarkers which can look at how to monitor the interstitial lung disease with these drugs. Pulmonary arterial hypertension, we of course have to do echo and the TLCO annually. We do the risk assessment, the endothelin receptor antagonists, and the PDE5 inhibitors are the drugs of choice. If you have inadequate, now you have newer drugs. You see this prostacyclin receptor agonist, which is selexipag, and you have the guanylate cyclase stimulator, which is raociguat. So these are drugs which can be used now for the pulmonary arterial hypertension. For renal crisis, we know, of course, steroids not to be given. Captopril is first line. There's a new drug here, which is called as eculizumab. Gastrointestinal involvement, of course, other than the proton pump inhibitors, we have newer drugs here. We have prokinetics. We have buspirone, which improves the lower esophageal sphincter tone. The prucalopride, which is for preventing bloating and early satiety. We have newer potassium competitive acid blockers also like vonoprazan. Now, if there's very resistant cases, we can go to hematopoietic stem cell transplantation. That's, of course, for when you have failed conventional drug therapies, or if you have major internal organ involvement, rapidly progressive severe diffuse cutaneous systemic sclerosis. Emerging therapies, you can block the dual pathways of inflammation and vasculopathy by specific antibodies now, which are coming in vogue. You have the PDE4B inhibitors, which are coming in, especially for pulmonary fibrosis. Then you have something for the T cell blockade, which is amilimumab. Then you have telitacicept, which is a one for the B cell pathway, that is for early diffuse cutaneous systemic sclerosis. And of course, you have the guanylate cyclase activator, which I was discussing, that is ivanaquab. So you find that now, if you even find with dermatomyositis, the 3 collagen vascular diseases are now coming to kind of similar pathways, and we're trying to get drugs also which are going to be similar. So probably, especially with the SLE and the dermatomyositis, so they are truly, if you see, so connected, and that's why probably now we're getting more inputs in the pathogenesis, and the treatments may definitely improve. Now, these are something very new. If you have cellular immunotherapy, this is the molecule which we are looking at, and various other drugs which are also in the pipeline. So we have a mechanistic research predominance with which I have discussed the molecular signatures. You have biomarkers, targeted and cellular therapies, and so you have personalized clinical pathways which will come in, which is truly precision medicine. So vasculopathy, autoimmunity, and fibrosis. For scleroderma, we all know that's most important. You have the EULA 2023, which shows the graded recommendations for organ-based care. We know that we need to recognize Raynaud's, the capilloscopy, the various vasculopathies early to recognize the risk, and we have newer therapeutic horizons now. Now we come to the third part of the presentation, which is dermatomyositis. And this is one disease which is now interesting me much more than the other two, and a lot of developments coming in. And this has now become a true mimicker, facial diffuse pigmentation, or you just have macular erythema on the metacarpophalangeal joints. I've seen cases where there was just some kind of erythema, and the patient had severe lung disease, and we have had mortalities. So it's very important to recognize the early cutaneous signs as a dermatologist so that we can prevent the systemic involvement. So we all know that the Bohan and Beta criteria had a problem. It did not basically identify amyopathic dermatomyositis, which I feel is very, very important for all dermatologists to recognize. So now this was a huge diagnostic gap because fatal ILD used to occur even without muscle weakness. So now you have the recent guidelines, which basically have included CADM, of course, and there is something which we will come to histologically, which is going to be very important. Of course, myositis specific autoantibodies have really changed the way the various endotypes of dermatomyositis have been delineated, and therapies can now look at varied options when it comes to these various different autoantibodies. So we all know there is juvenile and adult dermatomyositis when you have 7 years, and of course this is the adult age group. The malignancy risk is very high with the adults, whereas the vasculopathy and calcinosis are prominent in the juvenile. Interstitial lung disease much more common in the adults. We all know the clinical features, heliotrope rash. Now this is very important. In many cases, we may not get the violaceous kind of even erythema. I've seen many cases where there's just periorbital edema and you mistake it as angioedema. So please be careful when you see a periorbital edema. Keep dermatomyositis as one of your DDs. Gautrens papules, you may get even inverse papules. So look at the palmar aspect too. You may just get lesions on the elbows and the joints, and may look at times like psoriasis. And some of these lesions may ulcerate. So if you just have erosive erythemas on the elbows and knees, also I would feel the DD of dermatomyositis needs to be thought of. I have seen cases where these were the only features. Then, of course, you have the poikilodermatous lesions, which we all classically recognize as the Scholl sign, the Holster sign. Please look for them because these may be early signs even before systemic involvement. Periangual changes, that's another place where we can look at, and we can basically diagnose and also prognosticate the disease. So this eponyms, I feel, are not important. What is important is therefore the clinical descriptions. As I said, macular erythema just over the MCP IP joints itself could be a marker for cutaneous and therefore systemic dermatomyositis. So you have amyopathic, as I said, you have even hypomyopathic where you have minimal weakness, or you can have the classical dermatomyositis. Again, to remember that if you have a normal creatine kinase, it does not rule out dermatomyositis. The case where I had just erythema on the metacarpophalangeal joints did not have a raised creatine kinase. Isolated aldolase elevation is more important than the creatine kinase. So this is classic DM. We all have seen that. The key antibodies could be these, Me2, TIF1 gamma, NXP2. We'll come to them later. When you have amyopathic, please look out for MDA5, which is rapidly progressive ILD association. Antisynthetase, where you have the mechanics hands, CHO1, again progressive ILD. So now if you go back to the SLE pathogenesis, you see that there is interferon overdrive, endothelial targeting, complement deposition, capillary dropout. So this could be the pathway for pathogenesis here too. So this environmental triggers, toll-like receptors. So you go back and you find now that the collagen vascular diseases are getting interlinked with the pathogenesis now. You have myeloid dendritic cells overproducing the type 1 interferon, Here probably interferon beta. That is why the probably the relation that it becomes endothelial injury later, and the capillary dropouts which we see, and the fibrosis. The nail fold capilloscopy, of course, can detect the findings. The pruritus pathway pruritus could be a significant early finding in dermatomyositis, disabling pruritus, and that could be modulated by interleukin 31. Perifascicular atrophy, this is a classical finding, microangiopathy, and complement activation when you get it in the muscles. So if you look for the diagnostic funnel, you can have the clinical examination plus the nail fail videoscopy. Then you have serology. Now, what is important is the myositis specific autoantibodies. Then the targeted imaging, you can do a targeted MRI to locate the edema, and then you sample the most MRI active muscle with a biopsy. So clinical skin mapping, the MRI targeting, and tissue confirmation. Now, this is something important. Sarcoplasmic MXA is very important. That is the very important now for the diagnosis. It says it is 94 to 100% specific. We'll come to this. So this is the vastus lateralis anterior component, which is classically involved in dermatomyositis, and you have the sarcoplasmic MXA staining, which is now the gold standard marker for the interferon signature, 100% specificity for dermatomyositis. So this was what I was talking about, the myxovirus resistance protein A, MXA. So now this has come as an important marker. So if you add the IHC in the muscles and you get the MXA positivity, it is a new gold standard for diagnosis of dermatomyositis. So if you have anti-Tiffin gamma, you should definitely look for associated malignancies. NXP2, you can have calcinosis. You can have, of course, Me2 and for the skin and muscle, and MDA5 for the lung involvement, of course. So Tiffin gamma, as I said, you can have severe skin disease, highest risk of malignancy. You have anti-NXP2, which is a calcinosis driver. You do have associated dysphagia and muscle weakness. And this is, of course, juvenile dermatomyositis more common. Anti-Me2, which is a classic one, photo-accentuated rashes and good steroid response. And this is probably the best treated of the lot. Anti-MDA5 pulmonary threat, we all know that, rapidly progressive ILD. So you need to do with oncology, high risk with Tiffin gamma and also NXP2, whereas ILD is more with the anti-MDA5, that is a amyopathic variance. So there's another entity called as the mitochondrial antibody positive myositis. That's different. You can have various other associations like heart and the cholangitis. You have you can basically now score the disease with the cutaneous activity and damage score, the total improvement score, or the TM outcomes for muscle and skin. So treatment, this is one place where I generally don't go for hydroxychloroquine. Even the evidence says that it's not great. You also have various issues with dermatomyositis. You can give steroids, but since you need to give it for very long, you need to then replace it with steroid sparing agents. If ILD is there, of course, you don't go to methotrexate. And now we have the various refractory and target rescues like IVIG, rituximab, and various other drugs which we'll come to. We all know the issue with glucocorticoids. Of course, methylprednisolone pulse given very commonly in dermatomyositis helps the rapid muscle control. But of course, you should look at toxicity when you, of course, give it for long or for a high pulse dose. When do you choose the conventional DMARDs? You have methotrexate is excellent for skin, muscle, and arthritis. The problem is ILD, you can't use it. Of course, the toxicities. For ILD, mycophenolate mofetil is very good. You have problems like GI intolerance, of course. Azathioprine is also a good alternative. It is not as good as MMF when it comes to ILD. Of course, you know the TPMT association with it. So now, what is the problem with hydroxychloroquine is basically you have a resistance loop, which is especially triggered over the myeloid plasmacyte or dendritic cell. So that's why HCQ as monotherapy is not advised when it comes to dermatomyositis. Now we come to IVIG, very good for resistant dermatomyositis, skin manifestations of dermatomyositis, resistant cases, because it saturates the FcRn receptor. This is how it does it. And this is why IVIG is a very good drug when it comes to severe dermatomyositis, even muscle involvement as well as skin involvement. Now there are new drugs which are coming in which can act via the direct FcRn inhibition. So this is akin to the pathway for IVIG, but it is a next generation humoral targeting. You can see. So this is FGAR-TIGI mode, which basically binds to the human IgG1 Fc fragment, and then you have precision blockade with nipocalimab. So these are drugs which are coming in for FcRn inhibition as like IVIG pathogenesis, how it targets. Then you have rituximab. We all know it's very good when there is skin erythroderma, when there are skin manifestations. Not very good when it comes to calcinosis and alopecia. So now the anti-MDFI interstitial lung disease, we've had cases that does not respond very well with steroids. Rituximab is a good option here when it comes to the anti-MDFI. You see that 71% responds well. So that's a very good drug to go to early when you have the anti-MDFI antibodies. The oral JAK inhibitors now very good for the cutaneous manifestations. That is what is coming in for the JAK inhibitors. The interferon-induced cellular damage is very well controlled rapidly with the JAK inhibitors. So severe cutaneous lesions, pruritus, these are ones where you can use the oral JAK inhibitors. It could be life-saving when it comes to anti-MDFI ILD. That's another very interesting news and very good, so that we can use it orally, and also because it blocks the type 1 interferon-driven microangiopathy. So this is very good when it comes to the treatment options for the anti-MDFI ILD. Future pipeline, we do have humanized anti-interferon beta neutralizing monoclonal antibody like dezukibat. Then you have this drug which we have talked to you previously also in scleroderma, enpatoran and LE also. Then we have something which has a cannabinoid receptor 2 agonist, which is lenapezum. So these are new drugs in the pipeline. And for the calcinosis cutis, we know it's very difficult to treat, which is associated with the anti-NXP2. You have sodium thiosulfate protocol, which is doing well. And JAK inhibitors are supposed to be okay. So there's another place where JAK can do well. Of course, surgical intervention and nothing works. So these are the new drugs. You have interferon pathway blockers, brepocitinib and dezukibat. Then you have the targeting antibodies for the FcRn, which I talked earlier, efgartigimod and nipocalimab. Advanced cellular therapies with CAR-T being tried here, and upstream inhibition with the toll-like receptors, that is enpatoran, and the cannabinoid receptor, which is lenapazum. So interferon axis, now this is something which oral JAK inhibitors can block, and that's why that's coming into in a big way when it comes to treatment of dermatomyositis. So if you have various phenotypes, like you have the MDFI ILD phenotype, you go to the calcineurin inhibitors, JAK inhibitors, plasma exchange, maybe no methotrexate. TIF1 gamma, NXP2, standard immunosuppression, oncological screening is important, as well as dysphagia. Skin predominant, you can escalate to IVIG, or you can go to the interferon beta blockers or the newer drugs. Basically, that is, we discussed lenabazum. And if you're the classic type, then you want to go to the steroids and the standard steroid sparing backbone, which is methotrexate and NMF. So diagnosis is becoming molecular now. Normal muscle enzymes do not rule it out. You have to look at skin that will dictate the systemic risk. And now, as I said, you have the MXA, IHC to be done on the biopsies. So you need risk stratification, TIF1 gamma, MDFI to be very carefully looked for. And now you have targeted therapies like you have IVIG, you have JAK, the CART also. So skin is an important early warning for the systemic damage. You look at the myospecific specific antibodies, and you have precision treatment. So with this, I've come to the end of dermatomyositis and of course the 3 collagen vascular diseases. And I feel there's a lot happening in this field, and it's interesting. So all of you can read up this topic because the future therapies are going to be probably life-saving and very important. So that's why I covered it from a systemic angle also, because we know these are the same drugs which are going to help in the cutaneous manifestations too. Thank you so much.
Thank you, sir. Sir, can I share the quiz link now?
Yes.
Okay. And also, respected doctors, if you have any questions, you can share it on the chat. We'll be able to answer them. Respected doctors, in the chat we have shared the link for the quiz, and Dr. Vasudevan is open to take questions now. So do share your queries in the chat.
Yeah, so any questions I can take on? I do find a lot of familiar names in the audience attending. So if anybody wants any question, yes, you can answer. Sure to please type.
So we have 13 participants till now in the quiz.
Okay.
Now it's 17, increased to 17. Eighteen doctors have participated till now in the quiz. So respected doctors, we'll end the quiz at exactly at 9:25, and we will announce the top 3 winners for this quiz. Then we'll conclude the session.
Shubhadeep, there is a question.
Yeah, I've seen the question. So I feel just a heliotrope rash and with nothing else actually is
Sir, there is a question we have. A patient with
yeah, yeah.
heliotrope rash
No,
and no
I've
other
read it. I'm
systemic
seeing it. I don't know
abnormalities
if I'm audible.
found despite thorough clinical examination and laboratory investigations, including autoimmune and
Yes, so I can see the question. Am I audible? Yeah. So basically, what I feel is since the patient has only probably erythema around the eyelids and nothing else, then it's too early to start HCQS, and Vesepi HCQS doesn't do great with dermatomyositis. So I would feel tacrolimus is a good option. And sunscreen and keep under follow-up. So this could be basically an early CTD, if at all. And of course, then we'll need to look at DDs if there's anything like an allergic contact dermatitis, which is causing the erythema around the eyelids. Other DDs to be thought of. But just with the heliotrope and nothing else, I would be not be it would not be okay to start a patient on systemics. I think we can wait if everything else is negative and only the heliotrope rash, because heliotrope rash by itself cannot diagnose a dermatomyositis. So I would not start HCQS. Just put the patient on maybe tacrolimus and sunscreen is fine. Of course, to find if there's any alternate diagnosis would be important.
So, respected doctors, here we have got the top three winners for the quiz, and I'm just going to announce the names to slide. We have total 20 participants for this quiz. And these are the winners: Dr. Neha Solanki, HBTMC, Cooper Hospital. All of them have scored 15 out of 15, and it's only the timing who has taken the least possible time has won. So Dr. Neha Solanki comes first. Dr. Disha Sarkar from Medical College, Kolkata comes second, and Partho Sharathi Ghosh from Bardhaman Medical College comes third. And we have exciting prizes for them. We will be connecting with them after the session on Monday, and we will be sharing their yes. Congratulations once again to all the three doctors, Dr. Neha Solanki, Dr. Disha Sarkar, and Dr. Partha Sarathi Ghosh. So
there's been another question which I've answered on the chat. How to basically diagnose a amyopathic
yes, sir, you can
when to suspect and evaluate.
Yes, sir.
Yeah.
Please, please.